Good afternoon, everybody. Um, uh, Thank you very much for joining us this evening. We'll hopefully be providing you an update on upper limb nerve pathology. We've got an excellent panel here. First up, we'll have Professor Roger van Riet. Professor van Riet is a visiting surgeon from Belgium working in the Antwerp University Hospital. Professor van Riet is a world-renowned expert on elbow pathology, developing many techniques to manage elbow problems. He's trained through some of the leading units in the States, including the Mayo Clinic, and he's an invited guest speaker at a lot of these places as well. And Roger was just mentioning he'll be talking on the Mayo Elbow course, which is again a world-respected course in the next couple of days. So Roger will then be presenting to us on more proximal ulnar nerve related problems. And then we'll have Jagwant Singh joining us. And Jagwant is a highly trained orthopedic surgeon, an upper limb and shoulder surgeon, training through the Royal London training program here in London. Again, Jagwant has trained through world-leading units across America, including the Stedman Clinic and the Harvard Shoulder Unit in Massachusetts, in Boston, and Jack's been a prize winner throughout his training as well. And he'll be presenting to us on more peripheral ulnar nerve-related problems, and then I'll follow on with carpal tunnel as a separate topic in itself. So if we can hand over to Professor Roger van Riet to begin. Thank you, Roger.
Thank you for the introduction. Can you allow me to share my screen? I've got host disabled participant screen sharing.
Let me double check participants.
You have to give Roger the host access.
Host access. Well, just give that a try now.
I'm making it work. It's fine.
You working?
Yeah.
Yeah, it's working. Thank you. So hi everyone. Every time I speak here, I get introduced in a very nice way. My name is Roger van Riet. I work in Antwerp mainly, and a couple of times a month we try to work in the UK. Although they make it as hard after Brexit. I was asked to talk about ulnar and radial nerve problems at the elbow, of course, and hopefully I can shed some light on this problem. So the ulnar nerve is the one that's mostly involved in the elbow, and as you all know, the ulnar nerve runs through the cubital tunnel made by os pons ligament and by the deep fascia of the FCU, and on the other side of the tunnel there's bone. The motor function of the ulnar nerve, FCU and pronator teres, that's the first motor branch, and the surgeons among us know that we do our dissection onto the first motor branch. At minimum, I tend to go quite a lot further than that, because if we do revisions of these releases, we need to resect really quite deeply into the deep fascia of the FCU. It innervates the FDS, FDP 4 and 5 intrinsic hand muscles, as you know, and it's actually very important for the sensation of the capsule. So the pain at the elbow, medial pain at the elbow, can be caused in part by those branches going to the capsule. And then obviously, as you all know, ulnar side of the hand, half of the ring finger and the little finger are involved. Etiology, definitely local pressure plays a role. So avoid local pressure in patients that have symptoms. Prolonged elbow flexion, and our colleague Noorani very recently coined the term iPad elbow. And I think this is correct. So this position in bed, local pressure on the ulnar nerve, and prolonged elbow flexion. Obviously, it can happen with the cell phone as well, but these are two things that contribute to ulnar nerve symptoms. So symptom-wise, there's paresthesia, there's numbness sometimes, although it's often difficult to objectify, but definitely paresthesia, little finger, ulnar side of the hand, ulnar side of the ring finger. Paresthesia increases with elbow flexion and often worse at night, especially people who sleep on their front with their arms tucked underneath them. So that's one of the first things we do. One thing that I really often see in my patients is they tell me they feel clumsy. So you know, even if you don't ask them, they tell me that they drop stuff, they don't feel as good as before, and they like, for example, they drop a cup of coffee all of a sudden on their laptop. Clinical exam, obviously general elbow exam, range of motion, ask them if there's been any fractures that might have some bone in the cubital tunnel. T-Nels test. T-Nels test is basically you tap on the nerve, and if they get shooting sensation through the hand, it's positive. Although I have to say, in many patients, the T-Nels test, because the nerve is so superficial, the T-Nels test is very often positive. Hyperflexion compression test, that's the one I like the most probably. You hyperflex the elbow, you flex the elbow whilst compressing on the ulnar nerve with your finger. And if they get symptoms within, let's say, 20-30 seconds, then the test is positive. And don't exaggerate the test. As soon as they get symptoms, stop pressing on it, because they can feel it for a long time, especially those patients with really symptomatic ulnar nerve compression. They can have hypo or paresthesia in the fingers, like I said, most often at night, but sometimes definitely in severe cases also during the day while they're riding a bike, while they're in the car, etc. And then even further, atrophy, Wartenberg sign, and I'll show you later on what that means, Forman sign, and then we have the snapping triceps test, we will talk about later on as well. So this is bad for the patient. There's muscle wasting on the first web space, quite apparent here, and this is the Wartenberg sign. So basically, the patient is unable to adduct the fingers, where the little finger sticks out, and when you ask them to you know, get a flat hand, they'll be unable to do it. And this is a video of a patient, so even more atrophy. So this is a long-standing ulnar nerve problem, and I'm asking him to adduct the little finger, and as you can see, the other fingers are okay, but the little finger just doesn't want to go. And he's really trying. He's not making this up. And then typically, when you flex, you see that other muscles are helping, and you see that adduction. So fingers extended, and the ring finger, the little finger, opens up again. Very typical, but unfortunately for this patient, means severe ulnar nerve problems. This is Forman's sign. You ask the patient to hold on to this piece of paper, and as you can see on the right side of the image, or I think it's on the right side of your computer as well, you see how he's using other muscles, so he's using the flexor of the thumb instead of the adductor of the thumb. And by doing that, he's still holding on to the paper. Forman sign is sometimes difficult because some patients, especially if there's secondary gain, they, let's say, pretend to be weak, and you rip the paper out of the hand. Well, that shouldn't happen. This guy is really doing his best, and I can't pull the paper away from him, but he's using other muscles instead of the muscles used by the innervated by the ulnar nerve. Treatment. Majority of cases, even though this is an ulnar or a nerve problem, majority of cases do very well with conservative treatment. Up to 15% of people get ulnar nerve problems every once in a while. So that means in the audience, there will be people who wake up during the night with some numbness or pins and needles in their ulnar nerve region. To those people in the audience that have it, avoid flexion and compression. I have it myself, and I've learned myself. I fall asleep now with my arms straight. And it's basically, you know, in the beginning that's very difficult, but you get used to it and you end up doing it, you know, without thinking about it. You can use a night splint. I personally don't like them very much because they're usually quite big, and patients, you know, don't like sleep. It's like sleeping in a straitjacket. Patients don't like it. So what I tell my patients in the beginning, when they're still teaching themselves how to use different posture during the night, is get some tape. Not strong tape, it can be small, you know, painter's tape if you want, if you wish. Tape it at the back of your elbow, not in extension, but in about 30 degrees, so you still have some flexibility and some comfort. And then that tape will pull on your little hairs or pull on your skin or the little hairs at the back of your elbow. And every time you pull, you get a subconscious almost stimulation that you need to straighten your arm. And if you're sick of it, you just pull harder, it breaks, and you can sleep. And it just takes time. It takes sometimes months to get used to that new sleeping position. Nerve gliding exercises, they've been reported as being successful, and I do believe in them. However, the patient has to do them, and compliance, as we all know, is a big thing with these exercises, especially exercises that need to be done in a prolonged period. But still, if you do them well, they're often successful. When do we advocate surgery? If the nerve is clearly dislocating and painful and symptomatic. If there's atrophy, but unfortunately it's already a little bit late. If there's a motor deficit, again, motor deficits don't always return back to normal. And I do an EMG, and if the EMG is positive, that might be an indication for surgery separately, even if there's no atrophy, even if there's no motor deficit, because really you want to avoid those severe cases or those complications almost from compression. This is a patient of mine, ulnar nerve release, again, late, unfortunately, severe atrophy already, make an incision just posterior to the medial epicondyle. So this is between it's always the same spot. So it's between the medial epicondyle and the olecranon. And as a rule of thumb, my incision is as big as it is as the distance between the medial epicondyle and the olecranon. Find the nerve, release os bones ligament, and then go underneath my incision. So I do tell my patients they will get a hematoma because the incision, this one is relatively large, but normally do a smaller incision. I tell them they will get a hematoma because my release is far under the skin, 5-6 centimeters under the skin, both distal and proximal. And every once in a while I'll get a little vein that I can't coagulate because obviously the nerve is in the way. They don't mind the hematoma, they do mind big incisions. Because big incisions, especially the inside of the elbow, are not well tolerated. They stay painful, especially in bigger people. They stay painful for a long, long time because of all those skin nerves. And this is something special with the ulnar nerve. This is not the most common ulnar nerve problem, snapping ulnar nerve. With ulnar nerve compression, normal ulnar nerve compression, I tell my patients this is it's like a little piece of string around your finger. That's the compression. All I can do is cut that string. So I can't heal the nerve. That's impossible to heal the nerve with surgery. The nerve has to heal itself, and it takes a long time. But I can cut the string so the nerve can breathe again, so to say. And then, depending if your finger is already black by the time you cut the string, obviously the result's not going to be that good. If your finger's only red, like now, I release it, and then some patients, as you know, already feel better on the same day. But it can take 3 months, 6 months for them to get some benefit from the surgery. So snapping ulnar nerve is different. These are young patients, often very muscular, sometimes bodybuilders. They mainly have pain. So they mainly have pain on the inside of the elbow, and they might tell you that they have a click when they're exercising, for example, when they're doing bench presses or when they're doing push-ups, and some of them will have paresthesia. This is the test. Unfortunately, you can't see my hand, but what I'm doing, what I'm asking the patient is eccentric loading. So I tell them, push against my hand and let me win a little bit. That's sometimes difficult because those, especially the big guys, this is a normal guy, but the big guys, they really do not like letting you win. Even though you tell them this is easy, it's not a match, it's not a game, there's no prizes, but let me win a little bit, and they still want to push you away. But you need to get eccentric loading, and at about 90 degrees, in a very typical snapping tricep, snapping ulnar nerve problem, you get about 90 degrees, you get a little click, which is often painful, and then if you continue, you might get a second click, and the second click is a triceps. So firstly, the nerve is pushed out of the groove, as you can see here, and then secondly, the triceps. And you can see in this patient, the triceps is also dislocating over the medial epicondyle. It's not clicking because obviously the patient is anesthetized or has a block, but it's not contracting the triceps, obviously. So releasing the nerve makes the problem worse. So you need to do something extra. Just releasing the nerve like in a normal compression is not enough in these patients. As you can see here, we release the nerve, we transpose it, it's no longer dislocating, and as you can see, we also removed part of the triceps. Here's another one, and we actually see them quite often. This is a nice click, but again, you see the medial head of the triceps very deep, also dislocating. So in this case, we removed quite a bit of the triceps, so it stopped dislocating. One of the bigger complications that we see here, when you start cutting into a muscle, it really bleeds. And so even though we use our coagulation to cut through the muscle, still it bleeds, and you have to tell the patient this is a big potential complication. They need to be aware of this. This was a patient who already had a release elsewhere. The patient we did in London, and the nerve made a nice little room for itself, but again, very painful, distal symptoms, and he didn't have a big triceps, but he's still, shallow groove, and there you go, big click. These patients actually recover very quickly because the nerve's not too bad. The nerve is irritated, the nerve is painful, the nerve is swollen, but the inside of the nerve, so to say, the structure of the nerve is still good. So surgery for both snapping tricep syndrome and ulnar nerve, or snapping ulnar nerve syndrome and ulnar nerve compression, are very successful. The surgery is very successful. Complications are really rare. Luckily, we rarely see an infection. We rarely see wound problems. Hardly ever see stiffness. Every once in a while you get a nerve that might end up in some scar tissue, and if it does, then patients do develop stiffness. And for the physios among us, do not try to push them too hard into flexion if they can't. Start using nerve gliding, because the nerve, as you know, has to glide about 2 centimeters into the groove every time you flex your elbow and extend your elbow, 2 centimeters up and down. And if it's in scar tissue following surgery or following trauma, and you keep pushing, you get an ulnar neuritis. And what happens is that you get more stiff or equally stiff. And somehow, I don't necessarily know the mechanism behind it, but somehow if you push nerves, if you stretch nerves too much, they start protecting themselves, so you get fibrotic tissue on the inside, and they become more stiff, more painful, etc. Like I said, excessive bleeding we sometimes see after the removal of part of the medial head of the triceps, but usually, luckily, they do okay. CRPS, every nerve surgery can have it. Nerve injury, especially important, of course, with revision surgery, or when patients have already had some type of procedure done to the nerve. Very rare in primary surgery. And then, like I said, scar tissue leading to new compression. It's possible. It's also possible that the decompression was not enough, so that the release was not distal enough. Usually. Now the next one. This, for some of you, may be new, or at least seen exotic, because it's quite rare to have radial nerve problems. As you know, the radial nerve twists around the posterior side of the humerus, ends up on the lateral side, and then goes anteriorly and ends up anteriorly to the radial head, and then again rotates around the radial head to the back. At around the elbow, this is quite variable. This drawing is not accurate for everyone. This is like an average drawing, but it splits into two. You get the superficial branch, which is important for the sensitivity of the hand, and then you get the posterior interosseous nerve. That's the one we're talking about now, which is the motor branch of the radial nerve. Here you see the way, this is obviously not a patient, but a cadaver. You see the superficial branch, which usually branches around the elbow. So that's at the top of the picture. And then you see the posterior interosseous nerve disappearing in the arcade of Froese. And Froese is basically the sharp leading edge of the supinator. Actually quite a nice anatomical feature, because you usually see in this picture, you don't see that well, but you usually see like a V with fibers coming from one side, fibers coming from the other side, and then you see that posterior interosseous nerve surrounded by some fat disappearing in there. Superficial branch supplies the back of the hand, or part of the back of the hand, and a little part of the thumb. And usually, well, it's extremely rare to have problems with the superficial branch, unless, of course, you have a radial nerve palsy before it splits into two. But it's, an isolated superficial branch injury is very uncommon. Could happen with sharp injury, but usually we don't see that. So we're mainly talking about the posterior interosseous nerve, the motor branch of the two, and you can get pin palsy. Very clear. They get a drop hand. They can't extend the thumb, for example, or you can get radial tunnel syndrome, and this is the one that's controversial. Some surgeons don't believe in it. It's not a question of belief; it does exist, but it's rare. It's not a diagnosis that should be made easily. Clear pin palsy, either traumatic, either from I've seen it from cysts, from, for example, distal biceps tendon ruptures, or partial distal biceps tendon rupture, where you get a lot of swelling and patient wake up with the drop hand. I've seen cysts coming from the joint that caused radial nerve palsy. Obviously, when it happens in the humerus, you get radial nerve palsy, but then you have motor deficit and a sensory deficit as well. ECRB is usually the branch to the ECRB is before the supinator, so really not part of the radial tunnel syndrome as such. Then you have the supinator, then you have the extensor capial nares, etc., etc. You know the anatomy of finally getting the EPL and EPB. Like I said, pin palsy, trauma, or insidious onset. I personally have not seen a rheumatoid synovitis that caused the pin palsy, but it's been described. Parsonage-Turner is always part of your differential diagnosis if you have a patient with a lot of pain, usually pain and not a real cause of the pin palsy. And an iatrogenic surgery, unfortunately, is relatively common. Biceps reattachment definitely has been described up to 1 or 2% after biceps reattachment. Elbow arthroscopy has been described. There's a case report of a guy doing a tennis elbow, guy or a woman, I don't know, surgeon doing a tennis elbow release arthroscopically, and then ended up cutting the radial nerve, the median nerve, and the ulnar nerve, all 3 nerves around the elbow. So very brave that he or she published it, but simply should not been done. The surgeon should not have performed that arthroscopy. Radial reconstruction, especially if you use retractors at the anterior side, tendon ruptures and masses at the elbow. As you can see here, you see that just in front of the radial head, you see the cyst coming from the joint, and this pushes against the PIM. It's not huge on this little image, but it's actually quite big, and it pushes against the pin and causes the palsy in this patient. Like I said, biceps repair, and for those of you who use the endo button like I do, this is a very scary image. So this is in the lab, obviously. We did an endo button repair like we always do, and then we looked at the posterior interosseous nerve and look where it was. And as you can see, it actually, I'll go back. The button is actually touching the nerve. So this is maybe hopefully a severe warning. When you do these, do them in hypersupination. Supinate as much as you can at around where you see the sutures. That's where the hole is. So make sure that your drill is away from the posterior interosseous nerve. Radial tunnel syndrome, like I said, this is a little bit more common than radial tunnel palsy. It can occur simultaneously with tennis elbow. And sometimes we see patients who had surgery for tennis elbow and ended up not being better. And then we find a radial tunnel syndrome. Lateral forearm pain, diffuse, often quite burning, not so sharp, not localized like tennis elbow often is. And then weakness, but the weakness is secondary to pain. The anatomy, it begins anterior to the radiocapitellar joint. Usually there's no problem there unless you see a cyst, for example, an MRI if you look for it. The tunnel is about 5 centimeters in length, with the muscles on or the sharp edges of the muscles on the lateral side, and the medial side you see the biceps and the brachialis. So biceps tendon and brachialis muscle, posterior radiocapitellar joint, anterior brachioradialis. But really, the arcade of Froge is the place where usually the nerve gets compressed. It's possible that there's a vascular structure that compresses. The lesion of Henle goes over the nerve, and it has been postulated this is a vascular compression. This also is, in my opinion, is quite rare. I've shown you this before. Again, it's supinated with a 2-axis. The arcade of Froge there with the 1 axis, and then the blue arrow is the superficial branch, whereas the yellow arrow is the posterior interosseous nerve, so the motor branch. Clinical diagnosis is relatively subjective. Tenderness over the radial tunnel, pain at the ECRB origin with resistance of middle finger extension. This is from textbook. Pain with resistant form supination, EMG can be false negative. This is what's always been said. It's true to some extent, but there are some things you can do to improve your diagnosis. This is a paper by Srinath Kamineni, formerly based London surgeon who's now in Kentucky. He said, or he showed in a cadaveric study that if you pronate the arm, the radial nerve can be found in 100%, so in all of them, within 1 centimeter of the TED, which is the transepicondylar distance. So if you measure the distance with your finger between the medial and lateral epicondyle, and then you get that same distance, you keep the distance, and you go towards your listus tubercle, then the nerve is around here, at about 2/3. In 100%, it's in this area, but about 2/3 of this area, that's where the nerve is. And then when you press there, you can try it for yourself, it's usually painful. So that's why it's said that for me, that's not enough to perform surgery. Pain at the lateral side when you find the nerve, that's not enough to do surgery because it's always painful. I can hurt basically every patient if I want. But it helps, especially if you look at the symptomatic side and the non-symptomatic side. Because if you do that, then you often see that there's a difference between the two. This test has not been published, as far as I know. It's a test that we tend to do. I see the posterior interosseous nerve syndrome. I see this as almost as a compartment syndrome in the supinator. So I'm asking this patient to supinate against my resistance. You see that after about 15-20 seconds, he gets painful, and now I'm winning. Whereas before he was pushing me away, I'm winning. I'm pressing as hard on the other side as well. I do that on purpose, and I tell him, come on, do it, and he just simply can't. And then obviously it's very important. So they get weakness, they get pain, diffuse pain, and then you ask them, is this what you normally feel? Is this, or did we find it? And then they tend to say yes. And what we do then is we do an EMG in these patients. So we don't do EMGs in all patients, especially not when it's just pain or palpation. But this is when we do an EMG. And the guy that does our EMGs knows to fatigue them first. And I think that's very important. So fatigue them before you do it. Ask them to supinate against resistance and then do the EMG. Don't do it in rest, but do it after you've pushed them a little bit. As far as I know, there's no specific non-operative treatment. I'm not aware of nerve gliding exercises to do for that particular part of the nerve. Obviously, physio for if there is lateral epicondylitis, treat the lateral epicondylitis first, and then if there's still no radial nerve symptoms, you can maybe tailor your treatment to that. Tennis elbow straps are not recommended for patients with radial tunnel syndrome, and that's very simple. So when I test my tennis elbows, I ask them to resist or to extend against my hand in flexion. That's painful. I extend the elbow, do the same test. Has to be more painful in a true lateral epicondylitis, and then I push my thumb on the muscle belly of ECRP, ECRL, and then I ask to do them again, and it has to be less painful. Because the straps, as you know, they don't heal tennis elbows. They support them a little bit. I really tell them not to use them at all in rest. Don't use them when you're not using your elbow. Only use the straps when you're really doing something that you feel is too much for your elbow. And then the strap will help a little bit. Takes away about 20% of the pain. Use them for 5 minutes, maybe 10 minutes, but not much longer. If you have repetitive job and you think that you need to use them all the time, put them on, but don't tighten them. And when you need them, then tighten them a little bit. However, if there's radial tunnel syndrome, so if my tennis elbow strap test, let's call it that, if that's positive, if that's more painful, then we don't recommend them because you don't want to get more compression on the nerve. So be aware of it. Excuse me. Be aware of it. As you know, it's rare, but it does happen together with tennis elbow. Now, quickly about the surgery. There's a transmuscular brachioradialis splitting approach, so basically straight down through the brachioradialis. I don't know anyone that uses that approach, but it has been described. There's the posterior Henry or Thompson approach, which many people use. And I've got a nice video of that, which is not mine, which is Susan McKinnon. I use the anterior modified Henry approach. So basically a little bit distal to the biceps tendon, go in deep, find the superficial branch, find the supinator arcade of Frogier, cut the arcade and release the entire supinator muscle. This is Susan McKinnon's video. It's from YouTube. I cut it a little bit, obviously, to make it smaller. And there you can see all those branches. And you see, you actually, when Susan does it, you actually get a great view on this posterior interosseous nerve with all its branches there. We do slightly different. I don't have a video because my incision. Well, this is actually it's zoomed in, but my incision is quite small, and I feel that that getting a video in this case, I love doing videos, but in this case, I need to really have a good view on the nerve when I'm doing this. So I've been too scared to make a nice video, but this is basically the same. You see this, the released nerve, and you see the superficial branch. But this is from anterior, slightly deeper. So post-operative care, remove the dressing day 2 or 3, start range of motion exercises, then continue range of motion exercise first month, start strengthening after a month or 2. Really, this is not a cookbook post-op, because as you know, we don't necessarily do anything to the nerve post-op, so we can't make it heal faster. I tell them to use vitamin B. B6 and B12 have been shown to be maybe positive for nerve healing. I tell them to use that, and basically I tell them, listen, we've gone through some muscles, we've pushed the muscles away, the muscles will be angry at me and taken out on you. So do what you can, do not do what you want. And that's basically my view on rehab post both pin and both ulnar nerve, because really the nerve, like I said, we're cutting the string around your finger, the nerve will have to heal itself from then on. And you know, the decreased loading or not using your muscles or immobilizing is usually not something that we recommend, because you know it'll just take time. So in conclusion, all the nerve problems are very common. The second most common after carpal tunnel syndrome. It's a clinical diagnosis. Pins and needles in the little finger, clumsiness. I think those two symptoms are very important to recognize as ulnar nerve symptoms. I do an EMG for confirmation. Also, when you do an EMG pre-op, you have a base. So if patients don't evolve like you want them to evolve, you might do a new EMG to just check it. The treatment is conservative in the vast majority of patients, but surgery, if needed, is successful, and we tend to do this in situ release as a first choice, transposition if it's very unstable, or in a snapping ulnar nerve syndrome. And then radial nerve problems, they're very uncommon, although they do exist, and we do multiple cases a year. Again, clinical diagnosis, with the results of conservative treatment of this is unknown, but surgery is very successful if you select your cases well. So I don't do surgery on the radial nerve without a positive EMG, but like I said, especially in literature, they say, well, EMG doesn't work, it's always false negative. Find a person who does the EMGs well, tell them to stress the elbow, fatigue the elbow, or at least a supinator fatigue before you do the EMG, and you'll find them. If the EMG is negative, patients are sometimes are disappointed because they want you to find something. I do tell them, listen, you probably still have an irritated nerve. However, irritation is not compression. So that means that your nerve can still heal itself, and surgery will not make it better because that string around your finger is not compressing the nerve. And then I tell them, I could cut your nerve if I do surgery, so I can make it way worse. And then they accept it. It doesn't mean that maybe a later EMG, 3 months down the line or 6 months down the line, might become positive. But at least if you tell the patients, okay, this is going to happen, this is going to happen, it should get better by itself. Just your nerve is just irritated. Then they know how to look for the warning signs, which might be a palsy. Obviously, that's a big warning sign. Thank you.
Roger, great talk as always. Just a quick question from one of the audiences, and I think we know the answer to this already, but probably best coming from you. Snapping ulnar nerve, rather than transposition it, is it possible to deepen the ulnar groove to contain the nerve?
Yes, that's possible. It's been described. Why don't we do it? Because you're actually creating a very, very hostile environment for the nerves. So the nerve doesn't like when you start scraping away bone, or when you start, doing maybe a small osteotomy, the bone will start bleeding. The bone is rough. The nerve doesn't want to be there. And even if you cover the bone so the nerve doesn't get into direct contact, it will still be in a very hostile environment. We know from classic papers, the gold standard used to be an anterior transposition. The gold standard didn't used to be in situ release, and some brave people have started just leaving the nerve in a tunnel. And we know that in general, anterior transposition does very well. And so if there's a really unstable nerve, we prefer to do simple anterior transmission, and it's at least for me, it's more, I feel better, and it's more reliable than deepening the groove. Medial epicondylectomy has also been described, so you can cut away part of the bone. I've never done that. I found, I've got no experience, so I can't really say. I can only say why I don't do it is because changing the anatomy in such a way where you're taking away almost the base of the medial collateral ligament, where you're taking away the insertion of the flexor muscles. That's to me is a bridge too far, where we have really nice alternatives.
The transposition of the nerve seems to be obviously you only do it if the nerve is unstable, etc. But having seen so many of them, they do actually really, really well and do well really, really quickly. So it's a very predictable operation, as you said. Yes. I have been seeing a lot more ulnar nerve problems during the pandemic, right? So, I suspect a lot of people are working with elbows a little bit more flexed, right? So rather than sitting out there, they're more closed, flexed, more pronated. And I guess it may be typical to me, but I'm just wondering if any of the other panelists have noticed a slightly more increase in patients turning up with ulnar nerve symptoms in the clinics.
Yeah, Ali, quite true. I have seen a lot of patients coming with ulnar nerve symptoms. In fact, I'm seeing my list now, and in every list there's one ulnar nerve decompression for the next few months. So, so there is increased proportion now, and I think I agree with Professor Van Riet that iPad elbow is the reason why most of the patients are getting it the way they are sitting and spending more time indoors with the lockdown.
This was not my idea, Ali, and I give you credit, Ali. This was coined by Noorani. Came from him. And but I do think that this is a combination. You're sitting and you maybe a little bit more inactive, or many people in Belgium, I'm sure in the UK as well, have started working from home. So ergonomic circumstances were a little bit less than in offices, where you have a better chair, better seat, better computer, and at home you're sitting like I'm sitting now at the kitchen table with those who follow me on Instagram can see that my iPad. My MacBook stand is a bunch of books, so it's high enough, and I think that will increase symptoms as well. But iPad elbow, I really like it, and that's why I added this slide, because I think this is something new and definitely something to work with, because we can tell our patients, like I said, symptomatic treatment is very important, and this, if you explain this to patients, they sort of realize, well, okay, maybe I have been doing it wrong, maybe I do need something to put my iPad on, even at home,
Yeah, and while Jag is who is next is loading up the talk, I'm just wondering if you there was a test that we didn't really hear in medical school or during training, but I guess relatively new, called the scratch collapse test, right? What are your thoughts on that? So I don't use it, huh? But there's a lot on it everywhere. People trying to show it's a great test, but what are your thoughts on it?
Well, I do realize that this is going to be on YouTube for the rest of my life. I don't want to be too negative, but let's say it almost seems too good to be true, the videos that are on YouTube. Let's say that I think that's a politically correct answer. Almost too good to be true.
Fair enough, right. Perfect.
I have a question, Roger. The dissection you showed about the bicep button so close to the PIN. What would be your advice to the surgeons? Although we always do hypersupination when we are drilling, but is there anything else you would suggest to prevent that situation?
Yes, there are quite a few pearls, and I think we talked about that in the last webinar as well on the biceps. But hypersupinate, find the radial tuberosity. The tendon will always be on the ulnar side of the radial tuberosity, wrapped around the tuberosity itself. It doesn't actually, it only attaches a little bit on the tuberosity, but the tuberosity is used as it can. But if you do not put your pin right at the insertion of the biceps, so right at the landmark there, but go on top of the tuberosity. Just go in the center of the tuberosity. They will lose a little bit of rotation strength. I can assure you, that it's much better than going for 100% and maybe ending up with nothing. So go at the center of tuberosity and do not aim radially. So when you're aiming, don't aim distal and don't aim radial, but just aim straight down or even slightly ulnar. The problem with aiming slightly ulnar is that you might end up with a blowout of your tunnel. So be careful that you have enough bony architecture, that you have enough bone to get your tunnel in there. I always use, literally always use an 8mm drill, and 8mm is quite big. So if you go too much towards the ulnar side, you might have a blowout of your tunnel, and then obviously you have a problem with your fixation.
Great. Brilliant, Jag.
Roger.
Jag, you want to start, and there are a couple of more questions, but maybe Onur will answer them after Jag's talk, yeah?
Yeah, sounds good.
Thank you. Thank you, everyone. So yeah, my talk is on ulnar nerve compression at the wrist, which is not as common as the ulnar nerve compression at the elbow, and also the median nerve compression at the wrist, which Onur is going to talk about later on. So these are my affiliation. So talking about the ulnar nerve compression at elbow, it was Jean Casimir Felix Guyon who first described it, and he takes the credit. He's a French surgeon and described it in 1861. Not much happened nearly for 90 years. We had few more anatomic publications on this ulnar tunnel, and the eponym Guyon's canal made its entry in 1953 in the English literature. DuPont gave us the concept, the clinical concept of ulnar tunnel syndrome in his publication in 1965. Guyon was facilitated and acknowledged. There was a postage stamp in his name in 1975, I think. So looking at the anatomy of the Guyon's canal, we have the pisiform bone, which is the medial and the proximal extent. We have the hook of the hamate, which forms the lateral and the radial. Then the transverse carpal ligament, which forms the floor and the lateral side. The volar carpal ligament is the roof. The ulnar nerve comes in and it bifurcates. Looking at the anatomy more extensively, we see the pisiform bone, the FCU tendon is there, the nerve is there, the artery, the hook of the hamate, the transverse carpal ligament, which is the floor and the lateral side, the volar carpal ligament, which is the roof, and the nerve enters there. Then it bifurcates, and it bifurcates at the level of this fibrous arch, which is the most common constriction site of the deeper branch, which we'll study later on, is the motor branch. And that is where this fibrous structure can cause compression, especially of the motor branch. It is triangular, the Guyon's canal, and we see the FCU, the pisiform, the hook of the hamate. The most commonly described is the three-zone anatomy classification, where the zone 1 is proximal, the palmar carpal ligament, to the bifurcation of the nerve. And structures like ganglions, hook of the hamate, fractures can cause compression in this zone. The zone 2 is just distal to the bifurcation up to the fibrous arch, and that is where the motor branch can get compressed with, again, ganglions or hook of the hamate, fractures, or pathology. Now, the zone 3 is distal to the bifurcation, which is a superficial nerve branch, and that is the sensory branch. It gets affected if there is aneurysm to the artery or a thrombus. The three-zone classification really matches with the clinical classification now, which is responsible, the area and the site where the compression is leads to the symptoms. So in the zone 1, where the nerve is not divided, it will lead to both sensory as well as motor symptoms. Zone 2 is where the only motor branch is involved, and type 3 will be the sensory deficits because it only involves a superficial branch. So motor is the area where the deep branch is involved. The sensory is exclusively sensory is the zone where the superficial branch is involved, and any pathology into the zone 1 involves both sensory as well as motor components. The patients would present with burning pain in the palm. They would have sensory loss, as we've discussed in the ulnar 1.5 distribution fingers. The progressive weakness, they're unable to hold the objects, and there will be wasting of the thenar and the hypothenar eminence. On testing, you'll feel that there is a reduction in the grip and the pinch strength. In the cases where we have the Guyon's canal syndrome or the ulnar tongue syndrome, the sensation in the dorsal branch of the ulnar nerve and the palmar branch will be present. It won't be affected as it will be in the lesions proximal higher up. We always are mindful of differentials, the cubital tunnel, thoracic outlet, or any cervical root pathology. Sorry. What helps is MRI scan. If we are suspicious of any thrombus or aneurysm, Dopplers help, and nerve conduction studies are mandatory. We always get them for the patients. So again, the diagnosis, most common is the ganglion into zone 1 or zone 2. Then muscle anomalies, the palmaris brevis, the fractures of the hook of the hamate, again, is a reason why people would get on the Guyon's canal symptoms. Thrombosis or pseudoaneurysms are seen exclusively in zone 3, which are the sensory symptoms, which involve the sensory branches and cause the sensory symptoms. Burns, inflammatory arthritis, all these can cause edema, which leads to the nerve compression. Sometimes the nerve compression happens in young people because of repetitive activity onto the ulnar side, and that can also lead to symptoms. Again, be mindful of wherever the pathology is, it's going to give the symptoms. So proximally, both motor and sensory symptoms. Then into the zone 2, it's in the motor symptoms, and in the zone 3, it's the sensory symptoms or deficits. Uncertainty, it's caused by repetitive activity, which we can ask the patient to stop and their symptoms settle. Otherwise, a true decompression of the nerve is recommended. And what we do is a Z-shaped incision and decompress the nerve in the whole of the Guyon's canal. We go up to the fibrous arch of the hypothenar eminence to see, visualize, and release that motor branch, because that is where the compression can remain persistent. I have myself seen that in a couple of revision cases. In this case, you can see there was ganglion cyst, which is most common reason, but any hook of the hamate pathologies, any aberrant fibrous bands, palmaris brevis aberrant, and hypothenar fibers, they've all to be released, and a thorough release up to the deep motor branch has to be performed to make sure that there is no reoccurrence or persistence of the symptoms. So the surgeon should inspect for any masses, any thrombus, any aberrant fibrous bands, or any bony protrusions which can cause compression. Ganglion cysts, if there are one, they should be exposed, and all articular extensions should be resected. Guyon's canal is host to a nexus of nervous and vascular tissue, and the surgeon should be mindful of all of these to deal with them, especially these aberrant fibrous bands or aberrant muscular structures which can cause compression to the ulnar nerve. Thank you.
Jag, thank you for a great presentation, very, very precise for a specific problem. So thank you for that. While Onur is loading up, maybe there are a couple of more questions that have come through. So let's see. Roger, this is probably for you. It is about, can an adult get a pulled elbow syndrome during pull-ups? Now, my impression of getting pulled elbows are usually a pediatric problem, but your thoughts on that?
Yeah, it's a question of definition, if you call it a pulled elbow, but you can get a plica. So that many people have a plica around the radial head, and that plica can still dislocate. So it's not really like a pulled elbow where you sort of visualize that you're pulling the radius out of the annular ligament. but you can get a plica that sort of inserts itself between the radial head and the capitellum, and that can be very painful. And it can also snap back, but in adults, I think if it happens more than once, you need to just remove that plica and remove a little bit of the top of the annular ligament so it doesn't really dislocate anymore. So it's not a dislocated radial head as with children, it's a dislocation of the plica that's already there.
Brilliant, brilliant. That's actually very, very clear. Hope that answers Wendy's question. And there is a little bit more specific where maybe Jag or yourself can answer is, what are your thoughts on pins and needles on the medial forearm and the thenar eminence, aggravated by neck rotation, shoulder flexion, elbow flexion, and wrist extension? So we have medial forearm and kind of the radial side, thenar eminence, so it's the opposite side, pins and needles by neck rotation, etc., etc. So it's a very specific question. I would probably say that is more related to neck, if you're having any kind of neck-related rotation causing any pins and needles in your hands. So it's probably a cervical spine. Any other thoughts on that at all?
I agree. Look for maybe get an MRI of the cervical spine.
Correct.
Look for maybe an extra rib, a cervical rib that can sort of, because it was flexion of the shoulder as well, so it can play a role, but it's probably not something distal, especially not when you have multiple nerves involved.
And one for Jag. Jag, you mentioned you know, an MRI scan imaging, which is what I use as well if I was looking at any problems with the ulnar nerve at the wrist, because you can see a lot more. But there's a question from the audience to say, what are your thoughts on ultrasound assessment of the Guyon's tunnel? And this is for you as well as Onur to answer from your experience.
Yeah, it depends on who is your musculoskeletal radiologist and how much faith you have, because MRI gives us the option of that the pictures are going to stay there, and ultrasound is a dynamic examination. And I do use ultrasound sometimes for ulnar nerve at cubital tunnel, especially if there's a dynamic problem. But I think in this case, I would use a MRI scan that gives me a more extensive kind of, you know, clear idea about where the compression is and what exactly is causing it.
And Onur, yourself?
Yeah, totally agree. I personally use MRI scan more than ultrasound scan, looking at Guyon's canal, exactly reflecting what Jagwant has said. It gives you an ability to refer back to the images, especially if there is a space-occupying lesion and you're planning surgical intervention, so you can more accurately define that and address it when it comes to surgery. The only thing I can think of is with ultrasound, if you're thinking of a vascular cause, that may be more defined with ultrasound. But again, you'd have to be aware that it was a vascular related problem in the first instance to assess it through that means. So MRI as the main investigation.
Perfect, Onur. I think you are up now. Thank you so much.
Thank you. Good evening, everybody. I didn't get to kind of fully introduce myself earlier on. I'm a hand and wrist specialist working at the OS clinic with the colleagues present tonight. Otherwise, I work at the Royal Free Hospital, only recently started, and looking forward to kind of building up the hand unit there. So tonight's talk is on carpal tunnel syndrome, and I try and make it as evidence-based as possible. Essentially give you an overview of the condition, what I kind of tend to do personally, but also give you some of the evidence basis for that as well. So hopefully what we'll be covering is a little bit about the history, examination, investigation, treatment, a little bit on the anatomy, alternative surgical options such as endoscopic surgery, as well as looking at then some of the anticipated outcomes. So there's quite a lengthy classification of carpal tunnel syndrome, but more simply put, it's a symptomatic compression. of the median nerve at the level of the wrist, which is characterized physiologically by evidence of increased pressure, which attests to some of its underlying cause. And this leads to decreased function of the nerve at that level. It's the most common compression neuropathy of the upper limb, has a general clinical prevalence of around 3.8%. And this is based on some classic data from Sweden on 170,000 population. If you were to perform clinical studies and nerve conduction studies, the prevalence comes down to around 2.7%. It's more common in females at a ratio of 3:1, and a peak incidence is around 45 to 64 year age group. We are seeing an anticipated increase in the prevalence, and this is according to work coming out of Oxford, not only in carpal tunnel problems, but also cubital tunnel, trigger finger, as well as Dupuytren's disease. Increasing workload anticipated from this. So the pathophysiology of carpal tunnel is poorly understood, despite it being quite a common condition. The main thoughts to the underlying pathophysiology are that it's due to increased extraneural pressure in and around the carpal tunnel. This leads to an impairment of the blood flow to the nerve itself. Eventually, this leads to demyelination and axonal loss, and eventually fibrosis. So this is from Susan McKinnon, who's done a lot of work on nerve pathology in the upper limb, and it just gives you a kind of an idea of the progressive processes that goes on with compression neuropathy. There is a dose response to this as well. So studies done on the rat sciatic nerves with cuffs applied at certain pressures has replicated this pathophysiological understanding. Again, alongside this, I just wanted to highlight the fact that it is a progressive condition. At the early stages, there is a chance it can resolve. Carpal tunnel can resolve, but the long-standing compression will lead to irreversible problems. And this slide just kind of attests to that. So I kind of tend to think of the etiology behind carpal tunnel according to 4 different factors. The most common cause is idiopathic, whereby there is no true underlying cause, that at least as what we understand at this current state of play. Otherwise, one would think of intrinsic causes, extrinsic causes, and neuropathic causes. So this is again a diagram reflecting that. You can get intrinsic problems within the nerve fiber and the nerve itself, and these can be tumors or tumor-like lesions such as a schwannoma. You can get problems intrinsic to the carpal tunnel itself, and these are typically problems that can alter fluid balance. Inflammatory problems such as rheumatoid arthritis, which causes a tenosynovitis, and again, space-occupying lesions within the carpal tunnel as well. And these can be lipomas or ganglions. Again, not common. Extrinsic causes are things such as carpal fractures, and we occasionally see a dislocation of the lunate, or again, can be other carpal problems as well. And this puts a lot of pressure onto the structures within the carpal tunnel. Neuropathic problems such as diabetes or alcohol and hand-arm vibration syndrome is thought to have a neuropathic type pathophysiology. So this is just a diagram demonstrating a large lipoma actually within the nerve. There's the median nerve on either side of this large lipoma, just as an example of a large space-occupying lesion that once removed can improve symptoms quite dramatically. So some of the risk factors associated with carpal tunnel syndrome. This is a classic study from Derby and Nottingham, highlighting some of the risk factors associated with carpal tunnel. For example, previous wrist fracture, rheumatoid arthritis, obesity, osteoarthritis, diabetes, and some of the associated medications with some of these conditions. This is again the same from the same study, and actually found that some factors that we presumed would be associated with carpal tunnel isn't particularly found to be of relevance, such as smoking, for example. Again, studies on the genetics or the heritability of carpal tunnel syndrome has shown that there is an element of heritability at around 46%, looking at kind of monozygotic and dizygotic twins. And then more recently, again, work from Oxford using studies such called genome-wide association studies, where thousands and thousands, up to I think 12,000 in this case, tissue samples from carpal tunnel patients compared to controls from biobanks, and clever studies looking at the genome associations, and some particular genes have been identified, and these have been responsible for growth and extracellular matrix. And these genes have kind of implications for the nerve structure and the environment surrounding the nerve. So further work hopefully will reveal more along these lines. As we all know, carpal tunnel has a high prevalence in pregnancy. Clinical diagnosis of carpal tunnel syndrome has had a prevalence of around 31 to 62%. Nerve conduction studies reduce this prevalence, but still up to 43%. The hormonal fluctuations that occur during pregnancy seem to settle once the mother has had the baby in the postpartum period. So there's a resolution of up to 50% at 1 year, 70% at 3 years. However, there is a group of patients where the problems do persist. Night splints are very useful in such patients, and can help settle symptoms in 82% of patients. Because the symptoms do resolve, what we try and do for pregnant mums is to control their symptoms until at least they've delivered. Now, if their symptoms are really severe and we have to intervene, steroid injection has been found to be safe. As you well know, steroids are given to mothers to help with helping develop kind of baby's lungs. Although there hasn't been any particular studies looking at the safety, generally is found to be safe, more kind of anecdotally. If you had to perform an operation for really severe carpal tunnel syndrome, again, it has been found to be safe. Generally, we try and avoid any intervention and keep it as simple as possible. So coming on to the symptoms, what's really important with carpal tunnel syndrome is that we don't always see the classic numbness that occurs with carpal tunnel syndrome, numbness in the median nerve distribution, which is typically found to be the radial 3.5 fingers. Patients do sometimes come in complaining of numbness across the whole hand, and you perform nerve conduction studies and it's been proven to be carpal tunnel syndrome, or you perform a more accurate clinical assessment and it's again more carpal tunnel syndrome rather than a mixture of ulnar nerve and median nerve symptoms. Some patients describe this as a painful problem, so they interpret this numbness and tingling as pain. Some patients describe their symptoms as a burning sensation. Patients can describe ridiculous symptoms up the forearm. So again, this is all acceptable within the whole carpal tunnel syndrome condition. Patients describe classically a nighttime symptom, such as where they wake up and they have to flick the hands, so it's described as a flick sign. Symptoms can be activity related. We spoke earlier on about the iPad sign, but again, holding phones in your hand for prolonged periods, riding a bike, holding a pram, all these kind of activities increase pressure within the carpal tunnel syndrome and create some of the symptoms experienced. As Roger mentioned earlier on, patients become clumsy. They lose their fine dexterity. They aren't able to pick up coins or do up buttons. This is more often with advanced disease, but still often patients are dropping cups and objects, and that's often when they come to see you. So on the examination, more and more, we're employing kind of a questionnaire for patients, a diagram for them to shade in the area that they're experiencing some of their symptoms. So I feel that's quite important and often easily introduced into practice. But otherwise, sensation to soft touch is what I tend to do, compared to a normal area such as in the forearm or the contralateral side, and grade this out of 10. Assess abductor pollicis brevis strength. I don't find this as useful. I find more thenar wasting a more sensitive sign for this. I'll show you in a slide in a second the sensitivity and specificity of some of these tests. Phalens is the classic one. Phalens, you ask the patient to flex the wrists and hold them as flex for up to 60 seconds, and you wait to see if reproduces some of their symptoms. I tend to do what's called a modified Durkin's test. Durkin's classically was described as pressure over the carpal tunnel itself, and waiting for 30 seconds to see if the symptoms begin. If you were to flex and put pressure over the carpal tunnel, this modified Durkin's increases the sensitivity of the test. Tunnels is performed from a distal to proximal manner. And again, that can identify areas where the nerve is unhappy or compressed. Of course, it's important to rule out more proximal, a more proximal lesion or a double crush. So maneuvers around the cervical spine, doing a Sperling's test can be useful, as well as picking this up in the history. And of course, secondary causes. So looking at identifying problems with diabetes, for example, numbness elsewhere is important. So related conditions, just briefly touching upon, mentioned cervical disc disease. Classically, a disc at C6 or C7 reproduces the numbness in the C6 being kind of more thumb and C7 approaching more the middle finger. So that reflects or can be confused with carpal tunnel syndrome with the median nerve sensory pattern. Patients do tend to have more ridiculous symptoms with more proximal disease, and it's typically reproduced with neck movements, like we said earlier on. If this is the case, one should really perform an upper limb neurological examination rather than a simple examination that we did earlier on. And you look for things such as weakness in the wrist extensors or the elbow extensors. Pronator syndrome, I'll only touch on briefly. Pronator syndrome is compression of the median nerve more proximally. It originates just above, it can be problems just above the elbow to just below the elbow. The nerve can be compressed by different structures such as bony processes from the humerus or ligaments that traverse across the nerve, such as the ligament of Struthers. It can be compressed by the bicipital aponeurosis just below the elbow, as well as between the heads of some muscle groups such as the pronator teres or the FDS. Pronation supination often exacerbates the symptoms. Patients with more proximal lesions will have numbness in the palm. We'll talk about the anatomy in a second, but the palmar cutaneous branch exits before the carpal tunnel, and more proximal lesions will lead to numbness in the palm rather than just in the digits. Patients don't tend to have any nighttime symptoms with more proximal lesions as well. So this was a case of pronator syndrome. It's not a video, but highlights the steps taken to release the nerve more proximally. Clearly, it's more of an extensive procedure. And on this next slide, demonstrates what we did, which was release the pronator, the more superficial head of the pronator teres in that slide on the left. And then later on, they were crossing branches from the radial artery, which once released, you could see the point of compression. So again, a little variation of what we mentioned earlier on. So as promised, we got some of the sensitivity and specificity of some of the tests that we do. So for example, Tunnels has only a sensitivity of 50%. Durkin's with flexion increases your sensitivity up to 80%. Thenar weakness, as mentioned earlier on, not a hugely sensitive sign, but muscle wasting clearly are more obvious. So do we do nerve conduction studies in everyone? Not necessarily. I do have a low threshold for doing nerve conduction studies. I find it can obviously aid your diagnosis, but it's also prognostic as well. So if I find a patient is presenting clinically with very severe carpal tunnel symptoms, but nerve conduction studies suggest it's only very mild, you'll probably consider more conservative management, whilst if it's severe, you'll probably jump more to the surgical options. And also gives the patient an idea of how long to anticipate, how long the recovery can take. The more severe, the longer the recovery. It helps with a differential diagnosis as well, picking up more proximal lesions. It's not as sensitive for cervical problems, but it can isolate problems from kind of at least elbow downwards. The American Academy of Orthopedic Surgeons recommends routine use, whilst more local guidelines, such as those by the British Hand Society and British Orthopedic Association, don't recommend this as routine. It's worth looking at the guidance by the BOA and BSSH. It provides quite a nice overview of the recommendations. So according to the BSSH, nerve conduction studies are performed in patients who have an equivocal clinical examination, so one which isn't clear-cut, one where there is a possibility of mixed nerve symptoms, one where there may be some problems from the cubital tunnel, ulnar nerve, or even more proximal. I would definitely use it in recurrent carpal tunnel syndrome, and as mentioned there, kind of whether the diagnosis is unclear. So again, management of carpal tunnel syndrome, as mentioned, the commissioning guidelines by the BSSH BOA, but also useful is the NICE guidance, which is relatively up to date as well. So in my view, I tend to look at the clinical symptoms that the patient presents with, and according to this, that guides my treatment. So if patients present with mild symptoms, and that's very intermittent, numbness, tingling, or paresthesia, or occasional nocturnal symptoms, I consider them as mild. When the symptoms start to become more invasive, present through the day, becoming more regular, more persistent, it's becoming then more moderate. When it becomes constant, it's then in my mind severe and addressed, as we'll see in a second. So with regards to conservative management, in mild and occasionally having had a discussion with a patient in moderate symptoms, a trial of conservative management should be considered. Always provide patients with written information, and there's lots of good information out there from trusted resources like Arthritis Research, as well as the BSSH. Wrist splintage, especially in mild carpal tunnel syndrome, from large volume, low level evidence, has been proven to help. It has few complications. It's worth a trial. I personally find that patients come back and say it can be quite uncomfortable for them, especially sleeping every night with a splint. Some tolerate it well, others not so much. Of note is that prefabricated splints, such as these, tend to cock the wrist up at about 20-30 degrees. So if you can, there's a little metal bar in the splint, remove the metal bar and flatten it down to bring the wrist into more of a neutral position. Studies are looking at carpal tunnel pressures show that extension to about 20-30 degrees increases carpal tunnel pressure. So it helps by reducing the slight extension in the splint. So again, for mild, maybe moderate patients, a corticosteroid injection is indicated. And otherwise, especially in primary care, one should optimize underlying conditions for clearly kind of diabetes, improving blood sugar control. Non-steroidals and other things such as diuretics are not proven to help and are not recommended in management. Once having seen the patient, one should review the outcomes of any intervention after 4 to 6 weeks. And this goes back to what we were mentioning earlier on, is not letting patients suffer with the condition for long periods, as some of the problems can be irreversible, as a splint we saw earlier on. So steroid injection, again, mild, definitely, and maybe moderate disease. Interestingly, from a Cochrane study, only suggested short-term benefit from a steroid injection. This was back in 2007. More recent studies have shown a much more prolonged benefit, lasting up to 10 weeks and some up to a year. These other studies have shown 40 milligrams of depemedrone is sufficient. You don't need to go much higher than that. I personally don't use local anesthetic. There's no harm to it, but it really creates an unnecessary numbness following the injection, which is not really required. If one is injecting it to prevent a steroid flare, the flare comes on the following day and lasts for 1 to 2 days, and the local anesthetic won't have any benefit at that stage. Technique to perform it: an injection, obviously under aseptic technique, no touch technique. Between the palmaris longus, if one is present, and the flexor carpi ulnaris, just to the ulnar side of the wrist, just proximal to the wrist creases, and an angle of about 45 degrees. I tend to inject within the carpal ligament, as well as and some into the carpal tunnel as well. My thoughts are that this can reduce some of the thickening of the transverse carpal ligament, but that's purely my thoughts on it. Whilst doing the injection, any nerve irritation, one must stop and draw back, and one must never inject it obviously into the nerve itself, as it can cause irreversible harm. So referral to intermediate care, this is kind of to MSK physiotherapy level of care. This is based on resource availability. So if a corticosteroid injection can't be performed in primary care, then one would refer to MSK specialist input. One would also consider referring to intermediate care for moderate deteriorating symptoms. What physiotherapy can also provide is nerve glide exercises, and Professor Van Riet touched upon this earlier on. Nerve glide exercises, they're easy and simple to do. As mentioned earlier on, have to be performed for a reasonable period to have some benefit. I feel it should be used as an adjunct to some of the other treatment factors. In the literature, there's weak evidence for its benefit. The thought process behind it is that by performing certain nerve glide exercises, this can have a milking effect, allow the nerve to glide back and forth through the tunnel, which can improve its blood flow and maybe improve symptoms. So then referral to secondary care. We would anticipate referral of patients with severe symptoms. In my mind, patients with severe symptoms, I try and manage them as urgently as possible to give that nerve the best environment for healing. Failed trial of conservative therapy, then we'd anticipate a referral. And any red flags, so obviously injury related, if one was worried about tumors or nerve tumors, and things such as if there's inflammatory disease or neurological disease. Neurological disease may be better managed under a neurologist, and inflammatory disease possibly better under a rheumatologist in the first instance. But again, a referral to secondary care. So then coming on to carpal tunnel syndrome itself, as mentioned, is a treatment of choice in severe or failed conservative therapy. Two main options. One is an open carpal tunnel release, and the other is an endoscopic carpal tunnel release. The endoscopic can be formed with 1 incision or 2 incision technique. For me, it's a 1 incision technique if I tend to do it. Clearly, as one would anticipate, this is a day case or an ambulatory care setting, and urgency is dictated by the severity of the symptoms. Very briefly then onto the anatomy. I tend to place my incision slightly ulnar. This takes your incision away from the median nerve, and by moving, I'll show you in a second a slide, by moving your incision away from the median nerve, then the roof of the median nerve is the roof of the carpal tunnel, and it's away from healing scar tissue, so it gives you a better environment for healing. So we base it very slightly ulnarward, and this incision is from the distal wrist crease up to the point of which we call Kaplan's cardinal line, and Kaplan's cardinal line is a line drawn on the outstretched thumb. Going beyond that, there is a risk of damage to the vascular arch that comes across the palm. this wasn't a carpal tunnel decompression you'd be happy to hear. This is a tendon reconstruction procedure, but nicely highlights the superficial arch there coming across from the radial artery. So as mentioned, ulnar-based scar of appropriate length, and I don't tend to do my incisions small, but an appropriate incision so one can decompress the nerve safely and effectively. One should protect crossing nerve branches, and doing so, this prevents, in my mind, a painful scar and some of the other symptoms such as pillar pain that patients can experience. So again, cross-sectional anatomy there. You can see the nerve, there's a kind of cross-sections at two levels, one slightly more proximal and then the other slightly more distal. And you can see the nerve, and where I would do my incision is just very slightly ulnar towards the pisiform hammock, labeled as P and H in these slides here. And that just moves the scar away from, moves your incision away from the nerve, and a much kind of a safer environment for healing. And what we aim to do is release the transverse carpal ligament through your incision, and also more proximally, there's a forearm kind of fascia that runs across the flexor tendons, and you'd release that within the incision itself. Endoscopic release. So in an NHS practice, clearly this is a slightly more expensive procedure, although that's kind of being somewhat debated, and I'll show you some evidence for that in a second. This is the typical incision, and it's the more proximal incision that you can see here. Just a little kind of, I can't bring a marker up, but what I marked there proximally, just proximal to the wrist crease, is palmaris longus on the thumb side, and flexor carpi ulnaris, and then a little incision just between the two. And that's all that's required to kind of enter into the carpal tunnel. And the equipment just shown here, you do need a kind of a more specialist equipment to do it, which naturally increases the cost. But essentially, you can see there a little handheld device, which is a camera and a little blade. So this is a 2-incision technique that I've seen being done, and this is kind of a clinical picture from Caroline Leclerc at the Institut de la Man. And there's a 2-incision, one for the camera and one for the blade to do the release. And this is a diagram from the Institute. And this is kind of what you're seeing in a 2-incision technique, but it's similar in the single incision as well. What one does is you identify, I just bring this back a little bit and pause it. Oh, sorry. What one looks for is the ridges of the transverse carpal ligament, which run horizontally or transversely to the plane of your view, and you can almost feel the roughness of the transverse carpal ligament. There's little other finer things that one has to consider, but this is in principle. So outcomes of surgery. In terms of carpal tunnel syndrome, it has a lasting and a good outcome in 70 to 90% of patients. So these are patients who have weakness, a lot of functional difficulty, but with a simple procedure which takes 5 to 10 minutes in the operating room or otherwise, can have a very good outcome. Open versus endoscopic. So both have kind of similar outcomes as regards to the functional outcome. And even operative times in larger scale studies have been shown to be similar across the two. And according to looking at permanent nerve injury rates, actually the rates between the two have now been found to be similar. With endoscopic carpal tunnel syndrome, biggest advantage is that there's an early return to work. So kind of a more a global economic benefit to it. And this is an early return to work by 8 days. Really looking at kind of the small incision, less pain across the wrist. Key pinch strength is found to be better as well. Satisfaction rates have been found to be better, and as we would anticipate, scar-related complications are, as the scar is smaller, these can be better as well. The only problem is with endoscopic carpal tunnel syndrome, there is a slightly increased risk of transient nerve injury. As mentioned before, the cost can be slightly higher, and some studies done some time ago have shown that around to 100 to 200 pounds more expensive in the NHS setting. There is around a 3% conversion to the open procedure. This one has to convert to an open if you can't visualize the transverse carpal ligament clearly, or if there's a lot of tenosynovitis. So recommended to convert to an open, irrespective of your skill or ability. So open carpal tunnel decompression, some of the risks associated with the procedure, generally very low. So any of the significant injuries, such as neurovascular problems, damage to nerves, vessels, infection, wound healing, less than 1%. Scar tenderness and pillar pain, these are slightly more common. And just by virtue of doing an open carpal tunnel, performing an incision in the palm, releasing the transverse carpal ligament, there is an inherent finding that some patients will have some discomfort over the area. I encourage all patients to massage over that area. I think it optimizes the outcome. As soon as the wound is healed, I encourage patients to begin that scar massage, and I find that really helps. As well as some of the factors mentioned earlier on, such as protecting those little fine branches can help as well. In summary, what we've covered is then the pathophysiology, and what I want you to take away, this is a very progressive problem, so it is important to manage as early as possible. Interpretation of the symptoms by patients can vary, so take that with a little pinch of salt. We've mentioned some of the examination tips and looking at more related conditions, grading of the disease clinically, management of it, when to consider referral, and some of the surgical management options. So thank you very much.
Onur, that was a brilliant talk. Thank you so much.
Pleasure.
A couple of questions about injections. I think that there are a few questions that came in from the audience, and some of them you've answered about whether you do carpal tunnel injections just on the clinical presentation or you do any EMGs. And I think you answered that already. There's another question that came in about whether it's guided or unguided injections. So it kind of all comes back to my question on what the audience is asking really is, what is the safety around injections? Clearly, you know your anatomy, you do this all the time, but carpal tunnel is actually a very tight space, right? And it is relatively easy potentially to get it wrong and injure the nerve. So what is the evidence out there that who should be doing these injections? Should be guided or not guided? Are we encouraging GPs to do them routinely, or are we saying that we should have an ultrasound scan in most cases, or should they be done by somebody who does them very often, like yourself? What's your take on it?
So absolutely. So and this is interesting actually, and we've kind of discussed this quite recently, kind of in an NHS practice as well. So now I know the field has changed in general practice such that there is an increased, there has been a drive for training to do such minor procedures. So I know it's not as accessible as it used to be. I feel it is important to have training, and as with all things, if you're doing it occasionally, I feel it's probably better to refer onwards to either to the MSK level or secondary care. I feel, as you mentioned, there is risk of harm to the nerve, and you don't want to cause harm, which can be irreversible as well. So I think personally, if you're doing it as a high volume procedure, and if you're trained and you train well and do it appropriately, I feel it is safe doing it by palpation only. And again, little tips and tricks is injecting, for example, into the transverse carpal ligament first. There's a bit of resistance when you do that. I'd use a blue needle, so you feel that resistance, you get that proprioceptive feedback. To start off by a little bit of injection into the transverse carpal ligament. If you advance a millimeter at a time, and then there's a give of the pressure, then you're in the carpal tunnel. You shouldn't need to advance any more than that. But clearly that comes with experience and having done it a few times. Ultimately, ultrasound guided injection is somewhat safer. It has the added advantage of being able to pick up associated pathologies as well, predominantly space-occupying lesions. So in summary there, I feel if it's an occasional thing, ultrasound guided or referral onwards to a more specialist service. If you're doing it frequently, and again, the research supports this, is that outcomes are the same by doing them ultrasound guided or palpation technique only. So research supports both.
Fantastic. One last question. So, question from the audience is to you, Onur. What are the time frames to say that failed conservative management of carpal tunnels then refer on to consultants or nerve conduction studies?
So a short window. So I feel the benefits of an injection are noticed within a week or so, and if there's no benefit really at quite an early stage, then referral onwards. Now, NICE guidance suggested that steroid lasts only about 4 weeks. I feel that's probably a little pessimistic, and as I mentioned, studies have shown that they do last much longer. And guidance from the British Hand Society, British Orthopaedic Association has suggested, and NICE as well actually, refer if after 6 weeks there's been no benefit, either to MSK or to specialist secondary care.
That's perfect. I mean, that's quite an important take-home message because, nerves, whether in the hands or elbows, living, breathing structures, and when they have compression across them, some compression that can be tolerated, but significant compression can result in permanent damage to the nerve. It doesn't recover completely, even when you decompress it. And unfortunately, there are plenty of cases of that we see in our practice, especially in the NHS. So when the nerve is compressed, early referral for continuing symptoms is a way forward.
Absolutely. One thing I didn't touch upon, Ali, just which I think would be useful for our audience, is that there is evidence to support surgery even in severe carpal tunnel syndrome. So even those patients which you feel have quite advanced problems with muscle weakness and more permanent numbness, usually patients are a little bit more elderly in that kind of presentation. It's still worth us seeing them because there is a lot of evidence and also from personal experience as well. These patients still do benefit from surgical intervention. One, it stops the problem getting worse and progressing, and it gives that nerve an environment, a chance to start the healing process. I would warn such patients that the healing process can take several months, and often we say even up to 2 years. So I don't worry if there's been no change, but maybe just letting the patient know, providing that information can help. So still do refer those patients with severe problems, long-lasting problems.
That's a good point, Onur. There's certainly the experience from most of us as well. There are quite a few elderly patients, even with some muscle wasting and so on, that do actually benefit from decompression. In the long term, they are actually better off. I find there is a small percentage that have very severe compression, that they don't have any pain anymore, but they still have quite dense numbness and weakness and so on, that you release them, that they may actually have a rebound pain as well. Do you have that experience as well?
Yeah, absolutely. And again, it's just letting the patient know that it is a phase. I find it is a phase in the healing process where patients do come out of that and do start recovering. But for sure, exactly as you said, quite severe problems, probably kind of they've gone beyond the tingling and have gone more into numbness. You do the release and the nerve starts kind of almost waking up. It starts, the blood flow is improving, the kind of axonal flow starts improving, signals start traveling back and forth, and patients start developing some of that tingling sensation. It does pass, it just takes a bit of presence, but just warning the patient, exactly as you said, Ali, just warning them to anticipate that.
Brilliant, guys. Well, thank you all three of you for spending another evening doing the teaching. These talks are recorded and they will be going on to the Orthopedic Specialist YouTube channel. You will find that there are probably now hundreds of talks out there on all different topics. So please go and view them. You know, and I think it's a very, very important resource. So you can always reference them back. If you have any questions, please, you can reply on the YouTube channel or email us on our emails that are on each of our talks. So thank you to all the audience for attending and asking some really relevant questions. And thank you, Jag, Onur, and Roger for attending this evening.
You're welcome. Thank you, Ali.
Have a good night.
Ali.
Thank you.